This is for anybody who wants a little bit of help walking through the PowerPoint before our exam on Wednesday. If you have any questions at all, let me know before then. So this chapter, like I mentioned today in class, is kind of the flip of chapter 4, where we looked at the patient-provider relationship from the patient perspective. This one's going to look at it more from the provider perspective. So a little bit of how they were trained, the reasons why providers communicate the way that they do, and some of the barriers or challenges they face. So if healthcare providers were nothing more than a source of health information for us, if they were just something that we relied on purely for the information, basically we would just use Google or WebMD. There would be no reason to rely on humans. And if our communication with providers didn't matter at all, we could technically visit any provider and have the same experience, the same health outcomes, because providers technically have the same technical competence in a lot of ways. So our relationships with our healthcare providers are actually some of the most important and productive relationships in our lives, from birth to death. And in reality, there's no test or procedure or technology that can be used to heal patients with the most effectiveness unless it's coupled with good communication and good problem solving. And again, this is between patients, between providers, between third-party caregivers, whatever. But if we don't have good communication from providers, it often leads to medical errors or patients who are uninformed and then they make bad decisions or are unsatisfied and unmotivated. We waste more time and money in the healthcare services, and we have inconsistent patient outcomes. So a provider, I realize we never even defined what a provider was in here. It's basically someone who delivers healthcare services to individuals, to families, to communities. So basically, there's a very wide swath of what a provider can be. And so obviously we would think of, doctors, nurses, but also physician's assistants and nurse practitioners. Dentists definitely would. Pharmacists, which I don't think we've talked hardly at all about pharmacists in here yet. Paramedics, poison control specialists, so the people you call over the phone in the event of emergencies. Hospital chaplains, even people who come in and provide last rites or help give blessings to families or whatever. They could definitely be considered providers as well. And so even with the internet, even with all the sources of information at our disposal, researchers said that healthcare providers are still the most common and trusted source of health information for us. We still rely on them a lot. And so providers usually have to interact with patients in ways that promote shared meaning, like we talked about in chapter 1, build some sort of relationship with patients so that they can have satisfaction in this relationship, and lead to optimal health outcomes, obviously. But they face a lot of barriers. And just to kind of set up what we're going to talk about in this chapter, they're communicating with patients who are in high stress situations, which means they're way less likely to understand the information because they've just been told they've been diagnosed with cancer, and so then they have to grapple with what all this information means, which is really difficult. Doctors have to learn another language that they use to communicate with one another in med school and while they practice, and to patients it's confusing and it doesn't make any sense, and so doctors have to translate what they think is going on and what the patient needs to do using language they think the patient will understand and remember, which is not easy. They're like doing 8 things at once. There's not a ton of communication training in med school or even even in continuing education, things that are formal. You usually have to learn on the job by watching other people, or you get into ruts. You've been doing the same thing for 10 years and it's worked, so we stick with it, which isn't always great. Really hard to build relationships with patients depending on the job. So especially in the emergency room where there's high turnover and you get patients who are really rude or violent, or patients with really low health literacy, which we'll talk about in a later chapter. There's not a lot of time, again, to build relationships with patients. Face-to-face time is kind of limited. And like we mentioned, it's just as frustrating to providers sometimes that this face-to-face time is limited, because it's often out of their control. They have to keep the lights on, keep the patients moving in and out. And providers are often more satisfied when they have adequate time with patients, but they don't get that time a lot of times. Burnout and fatigue we'll talk about later in this chapter. So not only do they have to deal with physical and emotional burden all day, but the actual practice involves a lot of pressure and patience and endurance and emotional control that it gets really exhausting after a while. They also work in systems that don't always have patients' best interests at heart. So we have patients who have to deal with hour-long delays sometimes and waiting areas, and all for a little 15-minute meeting. And so obviously they're frustrated when they come back and meet a provider. So it'd be really difficult to communicate with some of these people. And so a lot of this has to do with how they're socialized, how they are trained to communicate during medical school. And so we've talked a lot about the voice of medicine, which is not really equipped to deal with emotional expression from patients. And we really, really strive in the voice of medicine for medical terminology and physical details about the patient, and not as worried about patient individuality or bodily conditions are the most important here, not really about the patient's experience. But also they're trained with this model or to use this type of language because they are faced with a lot of demands of time and emotion, and to kind of boil it down to its scientific, most basic components is supposed to help them get by, right? And so socialization means you're basically learning to behave appropriately within a specific community, and med school is a very kind of specific community. And so I feel like in this first 4 chapters or first 5 chapters, we talked a lot about how both the patient and the provider's individual behaviors would help improve patient-provider interaction. But really the best way to improve these communication issues and improve burnout and improve disclosing medical mistakes will be to look at how we teach medical students. So at the education level and also at the system level. Remember that example in the book about they had Japanese businessmen who ran like a Honda plant or something, and they had them walk through a hospital, and they were like blown away at how inefficient the healthcare system was, how inefficient the hospital was. They had these waiting rooms and these really confusing hallways, and what does that communicate to our patients? They're kind of like lab rats in a way. So I mentioned this today too, like when you go to med school, typically you have 2 years of classroom, so just classes like you guys are in, and 2 years of internships after that. So usually they keep these separate, 2 years of classroom, and then after you finish that 2 years, you get to go and do your clinical rotations. Like we talked about today with the OBGYN rotation, you also get like a psychiatric rotation, different general practitioner, pediatrics, that kind of stuff, ER, intensive care. And so then after those 4 years, you technically graduate from medical school, and then you do 3 to 7 years of medical residency, depending on your job. So like scrubs is they're all doctors, but they're residents. And this is where we get a lot of the kind of scut work where you're at the bottom of the totem pole. And we're starting to move more toward integrating those clinicals, those hands-on clinicals with the classroom science education, but it's still kind of separated in some places. So one thing to keep in mind, the average medical student learns about 10,000 words that aren't in general use outside of medicine. So if you're not a doctor, you don't really know these words. And, it can really create a barrier between providers and patients automatically, just in the first 2 years of classroom stuff. Because in these classroom settings, we often rely on rote memorization, where students have to memorize information without understanding it or applying it to actual situations. And so, you guys do this sometimes too, when you have flashcards and you just kind of remember the terms instead of applying them. And so when you have to get into an actual clinical setting, it's kind of jarring in some cases. So more of this focus on instilling technical competence is there than on maybe preparing providers to deal with different emotions or personalities they'll encounter with their patients. And so as a result, we get some of these compassionate elements of medicine that are overshadowed by the doctor's personal stress and by all the curriculum they're taking that emphasizes how the body is actually a mechanism. So think about how they train doctors to work with patients in some ways. They work with cadavers. My brother was the TA for an anatomy lab where they worked with cadavers, and kind of treats providers to think of the body as an inanimate object. So reducing it down to its kind of most basic components, looking at a person as a collection of organs and cells as opposed to a whole person with a life, right? And so as a result, we get patients' individuality and feelings and experiences being less important than their physical conditions, the things they're dealing with that we are trying to fix, right? And so we also have these kind of cold or clinical professionals come out of programs that focus on science but neglect interpersonal communication, social issues, ethics, all the things that the Wexner report we talked about in chapter 2 that came in and kind of standardized the science in the medical schools kind of wiped out a little bit with their emphasis on science. And it's helpful. It's really good because it helps providers kind of deal with the demands of time and emotion, and it suits our kind of view of providers as being really stoic and objective and in control. So one way that providers learn and students learn is through modeling. Um, and so we typically adopt the communication styles, logic, and attitudes of their mentors. So they follow the people who they're learning from, who suggest what communication strategies are helpful and appropriate based on the situation. And so if you have a provider or a mentor who's not good at it, then you're not going to learn a lot. You're going to learn a lot of bad habits. And so, typically our communication skills are learned on the job with patients or through interactions with other providers when you work on it as part of a healthcare team. And again, it might not be the best training to lead to the best health outcomes. It's kind of like you trial by fire. You see what works and you see what doesn't work and you go with what works. But again, it's not every way of communicating with patients is going to work for every patient. Um, so in the classroom and stuff, we can talk about how it's important to respect different cultures and respect different cultural beliefs. But when a student hears a resident or a teacher kind of dissing a patient, that kind of becomes the expected behavior. We start not paying attention to certain patients because they seem like pains in our ass, or like they're from a certain culture, and so of course they're not going to understand. So why even try? And so that's kind of why we have certain health disparities in some populations. Isolation is also a problem because when you're in med school, you're experiencing less time hanging out with family and friends because you're so busy, and the uniqueness of your experience of witnessing death, of literally having people's life in your hands, can kind of make you feel different from other people at first. And it's a very specialized community, and one that kind of sometimes, especially in doctors, view themselves as superior to the people outside of the system. And so it's starting to feel like people can't really question their judgment or authority in certain cases. And I noticed this even with my brother, and he's just a physical therapist. He's not even like a person who deals in life or death situations. And so I can understand why this would happen. And so, they start to identify with each other more than they do with their patients. And we talked about this too, paying dues, where you have to deal with kind of scut work. You start from the bottom. You're constantly telling people that you suck. They're trying to weed out people that, who aren't meant to be there. You have to get through this rite of passage to become a doctor. And then you come out the other side and think that other people aren't really in a position to question your judgment or authority because you've been through it. And then losing empathy. So your compassion and emotional availability for patients usually decreases during medical school. And like I said, you start to regard patients as enemies. If this patient died, I could sleep for another hour. And so I think the book talks about patients who are called drain circlers or gomers. So drain circlers is someone who's dying but hasn't died yet. They're circling the drain, and you just kind of wish they would die so you can have lunch. Or gomers, which is get out of my emergency room in whatever way or another. And it's understandable. I mean, if you walk in their shoes, if you consider what this would be like, I mean, reading that blood, vomit, and communication piece, especially the results in the findings section, really, really helps to see how easy it is to have this mindset and how necessary it might be. So remember, they talked about Sumner and his death and how kind of dignified that death was, or undignified that death was, and how sad the writer was, versus Turkey Woman, who she's like, oh my God, why don't we just die? And she's shocked at how easy it was. Some medical schools have kind of made empathy a part of their curriculum. So Northeastern School of Pharmacy, which is in Boston, have students actually like model the behaviors they would recommend to an obese or a diabetic person. So like the med students have to actually design grocery lists and shop for the exact foods, and like you have to work on this like limited family budget. So they actually felt a lot more confident counseling people toward dietary matters, and they felt more sympathetic toward them because they've done it themselves. They actually have walked in their shoes. All right, so really quickly, communication skills training. And this is, again, not just in medical school. We tend to leave providers alone after they're done, after they graduate, and I think we need more continuing education. So a lot of people feel that provider education programs should be equally concerned about ethics and social skills, and so that's why we put in 25% psychosocial focus on the MCAT, but doesn't deal with communication yet, which we need to get that in. And so here's something that's very unsettling. Like a doctor performs almost 500,000 interviews during their career. And so communication is a core clinical skill, but we don't treat it that way. Communication skills training is like a really minimal part of medical education for all types of healthcare providers, not just doctors, pharmacists, nurses, right? Physician's assistants, nurse practitioners. And so the AMA, American Medical Association, is implementing communication tests to their training. And so one thing is the Accreditation Council on Graduate Medical Education, which has three general areas, three general competencies. And so they define communication competence as the ability to interact effectively with patients, with family members, with their community members and colleagues from a wide range of socioeconomic and cultural backgrounds. And so the three communication competencies here, in order to be good at communication, is to be able to create and sustain good relationships, listen and provide information well, and work well with other providers. So it seems easy, but it's not. It's like everything else in this class, easier said than done. And so the best training programs, the best med school programs, use a range of experiential activities. So like role playing or observations or discussion, rather than just relying on lecture. And so we call this problem-based learning, where we get patients to kind of apply information to actual scenarios rather than just memorize it. So remember that story that we looked at with a patient who missed the West Wing. And that would be an example of how we're looking at an actual patient story and learning about that patient. Or what we did with motivational interviewing, or earlier today with medical mistakes, with disclosing medical mistakes. We actually got practice with that. And standardized patients, which are trained patients, are the main tool that these programs use, where we actually videotape role-playing situations in which providers are going to conduct interviews with these mock patients who are trained in certain things. And the providers supposed to practice their response to like symptoms and emotional concerns that are realistic that the patients present. And so sometimes it's unannounced. You actually have like standardized patients come in and hiding an audio recorder, or you're secretly being taped as part, and you don't know. Like you think they're just any other type of patient. So it's interesting because people who are putting providers through these training sessions can like play around with variables. So you can like practice with like different patient genders or different patient races, or like the patient's going to say different stuff, and see if the provider would like show empathy in certain situations or like react correctly in certain situations. And so usually afterwards, like the med student like reviews the videotapes with communication specialists and the mock patient, and talk a little bit more about that. And so often these are offered as an elective and not a mandatory aspect of continuing education, which is not great. Okay. So again, the goal here is to just like build rapport. Like how non-verbally attentive are you to the standardized patient? Did you encourage the patient to tell their story? Did you ask follow-up questions? Are you respectful enough with the patient? Did you present information clearly? Did you support them enough? That kind of thing. Okay. And then we talked a little bit about solar today, which is another skill that we have providers learn about their nonverbals. Just basically like demonstrating their interest in the patient, which we talked about in chapter 3. All right, so S is facing the patient squarely, sitting at eye level, so don't stand over the patient. Don't have so being at eye level, close to the patient. Create an open body posture. Don't have your arms crossed, basically. Okay, leaning in toward the patient as you're talking. Using eye contact, which demonstrates attention and interest. Think about what happens when computers are in the room, or you're staring at the chart or iPad or whatever, and then maintaining a relaxed posture, which will help decrease patient anxiety. Mention this again really quickly today in class 2, but SBAR is a way for healthcare providers to communicate with one another about a patient, especially when it's in like a really busy and complex environment. Like I mentioned today about how my mom, who she works in imaging, and so when she gets patients from the emergency room, she usually gets instructions in written form that uses this same structure. Okay, so it's a way for to kind of prevent communication failures and clearly and effectively communicate information about patients within this really busy and complex environment. So situation, background, assessment, recommendation. You can read over these, what these are. But usually like intensive care, emergency departments, operating rooms. And so, like you have a provider who has a clear idea of what they're going to say and is much less likely to leave out or forget to convey important information because they have these steps they have to achieve. And so it's also good for the person who receives this information because they're brought up to speed really quickly on the patient, and then they're asked for input. They're asked to provide more, right? So the kind of the question is here. I mean, we have medical students who are asked to do a lot. Like obviously they need some communication skills training, but at what cost? So if or when the point comes when it's necessary to choose between more instruction in science or in medicine and more instruction in people skills, like think about what kind of instruction might be more important for physicians to have. So that might be a discussion we'd have in class, and it's tough. I mean, you have to kind of find a balance. You have to find space to have communication in there, but you don't want to also risk their ability to know medical information, right? But it's also important to know that patient satisfaction scores rise among the patients of physicians who actually do take part in these communication skills trainings. So the more doctors are trained, the more the patients are satisfied, and it's often because doctors tend to give more information, they tend to show more sensitivity, address a wider variety of patients' lifestyle behaviors than people who don't take part in these programs. Okay, a couple more things quickly. There's the Nurses Need to Now thing if you want to watch it. We will save this for a later chapter in technology. So burnout. Burnout is something that's a lot more common in healthcare than in other fields. It's similar to that story I told you about my mom, who is an emergency room nurse, and by the end of her kind of run in this really busy and really kind of stressful environment in the emergency room in downtown Columbus, she wished she would get in a car accident on the way into work so she wouldn't have to go in that day, right? And so pretty tough. It's a pretty tough work environment. And so it's typically described with three different things. So emotional exhaustion, you have all these overwhelming demands which depletes your energy, really hard to get motivated for work or feel compassion. Depersonalization and cynicism, which you feel very detached from your job. So you start treating people in a way that's very unfeeling or impersonal. You might resent people for being weak or incapable of caring for themselves, or that they're really annoying. And then personal accomplishment, feeling like you haven't achieved anything. You feel like a failure all the time. Like you're inefficient and you have never achieved anything. And so 40 to 60% of physicians currently experience burnout. And then annual suicides are actually 2 to 3 times the average number of students in a medical graduating class. So think about that. So of all the students in one medical graduating class from one university, usually around the world every year, 2 to 3 times that number kill themselves. Right? Job dissatisfaction among hospital nurses is 4 times greater than the United States average. 1 in 5 hospital nurses usually want to leave their job within the year, and burned out doctors are more likely to be diagnosed with depression, definitely engage in substance abuse, commit suicide 3 times the national average, commit medical errors, so accidents, and leave hospitals understaffed. So, which creates a barrier to quality care because there's so much turnover. You have so many people who don't have experience, and also experience more heart disease, have literally worse health outcomes. Okay, and then also when we have patients of physicians with a lot of burnout, their patients feel less satisfied. They actually recover more slowly, leave the hospital later because their doctors are less attentive to detail, didn't have open relationship with patients, and so really working to get rid of provider burnout can help patients too. Okay, because you have physicians who are less attentive to detail and have less open and trusting relationships with their patients, and they're more likely to leave the field. So here's the causes really quickly. First, competing and ambiguous demands. So nurses have more tasks than they can complete. A lot of nurses have to work holidays and weekends. I remember my mom had to do that a lot, or be on call all the time. So they're given demands that are conflicting, or it's inappropriate to disrupt physicians, and maybe don't feel support or rewards from their organization. They're asked to carry out treatment decisions that they believe to be inappropriate or harmful to patients because they're being told to. That's called double bind, where you don't really have a say, but you're being told to carry out a treatment decision that would not work. Okay. Detached concern. This is part of emotions because you expect your providers to be quick but really thorough, really strong but emotionally accessible at the same time, always available but never tired, always honest but also never capable of making a mistake. And so that's a lot of pressure, and providers are rarely given instruction on how to care for themselves or how to manage their own stress and burnout. And so detached concern is that, you have a sense of caring about other people without becoming emotionally involved in the process. So kind of this expectation that, you'll avoid your own emotions, um, which might lead you to become apathetic or cynical. And your energy and compassion kind of drain slowly, but not all at once. And the kind of ironic thing is that this empathetic communication model of burnout, which means, you know, um, people are attracted to healthcare because they're concerned about other people, and they're typically good communicators, and they're typically able to communicate well with people in distress. But because you're so empathetic, you're more likely to feel overwhelmed by being constantly exposed to emotional situations, and so the empathy that initially attracted you to this job can start to be overwhelming because you're kind of drowning in all this emotion that you're so sensitive to. And then in that blood, vomit, and communication article by Hirschman, the fact that the residents are trained on the job, and at least in 1999, I know that the medical system has changed a lot since then. But in their internship year, it's kind of the first year of your medical residency where you have the most work to do and the least experience, and it's literally trial by fire. It's like initiation. And back then, I don't think they're allowed to do this anymore, but they had to work 48-hour shifts, so straight 48 hours, which is very stressful, not really a good environment to learn or to communicate effectively. And so, not really many opportunities to develop the communication skills necessary for a physician's later clinical skills, or later clinical career, and a lot of poor educators that were described in this piece. For example, they're often told to kind of hide their uncertainty and replace it with this facade of authority and decisiveness because they don't want to look dumb. Remember when they went around and had did the rounds at the beginning, right? And patients are all often viewed as being victims of the disease or objects for learning and subjects for research. And so, like I said earlier, Hirschman was shocked at how easy it was for her to lose her empathy when she was faced with that disgusting turkey woman, right? And especially, she did 2 40-hour shifts. Like, imagine dealing with disease and death on a daily basis for years and years. And she literally said, come on, lady, just get it over with and die. Also dealing with difficult patients, which you read in that NBC piece by Alicia, abuse by patients. So, think about the jobs you've had, like in retail, where you're getting yelled at by people. And imagine that when you're trying to save the person's life or you're trying to treat the person. And so over 50% of emergency nurses actually report verbal abuse in a year period, which is a big number. Like 50% of nurses experience that. Okay. And 13% experience physical abuse. And so, like, why do you think the emergency room would make this kind of behavior more likely? Well, it's really a stressful environment. You get people in there who are really not in good shape, probably very low income, maybe on drugs or alcohol, or have been shot or something. You're dealing with people sometimes with mental abuse who feel like they're being attacked. And so I think and again, this is something else I asked my mom about, like, what do you do when you're faced with a patient who's so difficult, like physically and emotionally abusive? And, she said, just try not to react as much as possible. Be calm, because if you get aggressive back, you're just going to make the situation way worse and it's going to blow up. Okay. They often feel like they're not good at communication. So if they have unsatisfying communication with patients, if they feel like they don't have good relationships with their patients, they're 2 to 3 times more likely to leave the profession. And so patients who are friendly and upfront about their needs actually help the physician avoid burnout. So think about if you go to the doctor and you are nice, and if you're upfront about what you actually need, you're more likely to help the provider enjoy their job. Right. And so providers are more likely to burn out faster if they don't think that they're good communicators. And it doesn't matter whether they are or aren't. It's just, it's just how they perceive themselves. And, if they feel like that they communicate well, it might enhance their confidence in their relationships, which are two things that we know will buffer stress and prevent burnout. And then finally, workload. Having to deal with really excessive work or things that are monotonous or repetitive. And we talked about managed care a lot in chapter 2. The business demands. Only 3% of physicians don't have to deal with things like reimbursement and liability, and paperwork, overwhelmed by regulations and policies. So all that stuff does not keep people in the field. All right, so we talked about medical mistakes in class. We're going to skip that and then really quickly go through interdisciplinary healthcare teams, which, one way to improve the communication that leads to these mistakes is to have a group of physicians, a group of providers working together to, treat a patient. And so, especially in the most complex care situations, in hospitals and healthcare organizations, they use interdisciplinary healthcare teams. So, for example, my friend Anna, who went to get her PhD with me, she did her dissertation on vascular malformalities, which are like birth marks that are on patients' faces, and especially with pediatric patients. And so she would go and kind of sit in on these interactions between patients and their parents, and like little kids who have birthmarks, and their parents don't know if like this is a sign of something serious, if they have like a tumor or something. And so they bring them to Children's Hospital in Cincinnati, Ohio, and they're looked at by like a group of 10 providers. And so surgeons and a general practitioner and social workers and dermatologists and plastic surgeons and all these people who help treat the patient and their families. And it's nice for these families because the Children's Hospital system is so good in Cincinnati that they come from hours and hours and hours away. And so it's almost like one shop stopping. You get to see all these providers at once. So yeah, in most complex care situations, individual providers can't care for patients without some kind of collaboration from other healthcare professionals. And so, it can help kind of ease some of that pressure on the healthcare professional because you're working in a group. It's not just all on you. So the book says to describe it as it's not so much like baseball, where you have each player kind of assigned a position with a specific set of tasks to perform. That's kind of what we're working with now. We have a specialization. So we have, like I mentioned before, physical therapists and athletic trainers and general practitioners and orthopedic surgeons and strength conditioning coaches and other coaches and nutritionists. And they kind of stay in their own lanes, right? They're specialized, they're precise, they don't really communicate with each other. So what interdisciplinary healthcare teams are like, it's like tennis doubles, which is faster. You have people who kind of like help each other out. They're ready for the unexpected. They're ready to cover each other's butts, that kind of thing. Okay. So we talked about too about how, when you have all of these different practitioners not communicating together, you can have a patient who has all these different duplicated medicine, duplicated treatments, contradictory treatments, which results in a lot of delays and mistakes, things that cost a lot, frustration, wasted time, and these providers aren't able to see the larger patterns happening here. Okay, so teamwork can help minimize some of that waste and frustration. And so, the Mayo Clinic does this. They have a fully integrated system of doctors and specialists and therapists and labs needed to provide comprehensive medical care. And so everybody on this team works for the clinic. They all stay there. And like Anna's study, as I was mentioning before, it's called Destination Medicine, where, as you as a patient come, 3 to 5 days on the same campus, versus if you had to get appointments with all these individual providers, it would take weeks or months, right? And so you make appointments through one centralized system, and the providers have all your access to your records, your test results, other providers' notes. Everybody gets a full picture instead of some sort of fractured picture. Okay. So good things, we get multiple perspectives. We're going to minimize waste. You don't lose patients in the system. So because you have different specialists, you get to see the patient's physical, psychosocial, spiritual health problems. Less pressure on the provider because they have other people holding them accountable, other people that can help them. It's less pressure, less fear of a mistake, and they feel like they have greater job satisfaction because you get to work on a team. You feel less alone. And yeah, fewer errors, like I said. Some of the bad things, some of the difficulties, it takes a lot of time. Emergency situations need quick decisions. Busy schedules really make it hard to schedule meetings, especially if the organization isn't supportive and allowing time to train. Groupthink, which when team members are rushed or intimidated, they might just kind of go along with the ideas they would normally support. You have physicians who are in their own specialties, like family practice and cardiology and surgery and radiology, and nurses. So nurses even have, like, are you an operating room nurse? Are you a hospital floor nurse? Are you dealing in medical records? And so these specialties kind of create your own specialized vocabulary and different clinical functions that are sometimes difficult to transcend. And so, sometimes these professionals have different disciplines that are often very different, often have very different ideas about health. And so you might have some sort of competition and conflict there. And so, like if you have somebody on this healthcare team or interdisciplinary team that's low ranking and or non-clinical, like a radiology tech or something, they might be treated with less respect than doctors and nurses might be treated as subservient to doctors. Okay, so all these things need to be kind of sussed out on the interdisciplinary team. Okay, so really quickly, and yeah, conflict has to be taken care of as well because not good decisions are not made without some sort of conflict. All right, really quickly, I want to give you some examples of healthcare team members that you guys as communication members are uniquely qualified for. And so this is my friend Grace Rodney, or Grace Jones now. She got her master's with me at University of Dayton in health communication, and now she is the communication specialist at Dayton Children's Hospital. So she is an expert in communicating in face-to-face or in small groups or in large audiences through mass media. She does a lot of PR for the hospital. So she does a lot of campaigns, fundraising campaigns, marketing for the hospital. So those of you interested in PR, one of the giant areas is healthcare PR, right? So she works to educate the public through campaigns. Other communication specialists help train physicians and patients to develop some communication skills, help manage crises both within the hospital and outside of the hospital. And like Grace typically does, develop health marketing and public relations stuff. This is Joan Scales, who's a social worker at University of Kentucky Cancer Center. She always came in and talked to my class. She would train patient navigators, which are people who kind of serve as a liaison or a connection between patients and the healthcare system. So patients and families kind of come to them and they might ask questions that they feel more comfortable asking to a patient navigator than to a doctor. Things that maybe they might not perceive the doctor not to have time for, or they're embarrassed to ask the doctor. And so they usually ask to make sure that patients and families have the information they need, are satisfied, help them to navigate the system. So if they need to make an appointment elsewhere or need some sort of quality of life care, the patient navigator can help. And I remember when I did research at the Cancer Center at UK, they had a whole room devoted to wigs, just like where patients can come in and get fitted for a wig. And that's one of the things these patient navigators did. So yeah, they get and understand information from the providers, but they also, help the patient, get tested, find out about other resources on a psychosocial level. Okay, so that's basically it. Again, if you have any questions at all, just let me know, and hopefully this was helpful. All right, talk to you guys later. Bye.